Hi everyone, today I'll be discussing the anatomical and pathophysiological changes that occur in chronic bronchitis. To begin with some context, chronic obstructive pulmonary diseases, abbreviated as COPDs, are conditions caused by the obstruction of airflow, especially during the expiration stage of breathing. This results in symptoms and signs such as dyspnea, excessive production of mucus, and frequent coughing or wheezing, progressively getting worse with time. COPDs are typically diagnosed through spirometry lung function tests. These tests measure how well air is expired by producing a ratio between the amount of air expired in 1 second to the total volume of air exhaled in one breath, known as the FEV1 to FBC ratio. Typically in physiology, we see that the ratio is greater than 70%. However, in patients with COPD, the ratio is found to be less than 70% after bronchodilator is administered. COPD is divided into two main types, chronic bronchitis and emphysema. Chronic bronchitis is a result of long-term inflammation and scarring of the bronchial tubes. It is clinically diagnosed when the signs of a wet cough have been persistent for at least 3 months per year over the course of 2 consecutive years, in addition to spirometry testing. Emphysema is the breakdown of the elasticity of lung tissue due to damage of the alveoli, causing them to collapse upon expiration. In addition to spirometry testing, chest X-rays and arterial blood gas analysis are commonly used to confirm emphysema. It is important to note that most patients diagnosed with chronic bronchitis also have emphysema. In 2019, the World Health Organization listed COPD as the third leading cause of death worldwide, and it was responsible for approximately 3.23 million deaths. Approximately 90% of COPD-associated deaths occurred before the age of 70 in low to middle income countries. It is important to note that COPDs are commonly misdiagnosed as asthma due to their similarities in symptom presentation. Additionally, breathlessness, a common symptom of COPD, can be overlooked by physicians as it is commonly thought of as an acute condition. COPDs develop gradually over time and is usually a result of a combination of risk factors such as tobacco smoking, air pollution, issues occurring in the early stages of life such as prematurity, and recurring lung infections that prevent maximum lung growth, asthma, and a rare genetic condition called alpha-1 antitrypsin deficiency. But the most common cause for developing COPDs, and specifically chronic bronchitis, is tobacco smoking. Looking at the diagram adapted from slides 19 and 21 of Lecture 10, we see that a stimulus will trigger an influx of inflammatory cells and the release of cytokines, resulting in systemic inflammation. This inflammatory state is using up the body's supply of oxygen for physiological function, causing hypoxia. Prolonged hypoxia can lead to depression, bone and metabolic diseases, as well as cardiovascular conditions. And prolonged inflammation can lead to emphysema or chronic bronchitis, which can result in airway obstruction, air trapping, loss of surface area for gas exchange, frequent exacerbations, presenting in the form of dyspnea, cough, hypoxemia, hypercapnia, and cor pulmonale. Now focusing on the pathophysiology of chronic bronchitis. Chronic bronchitis is essentially caused by the overproduction and hypersecretion of mucus by goblet cells. This occurs when a stimulus such as nicotine in tobacco smoke activates the neutrophils, which release inflammatory mediators. This causes the bronchial mucous membrane to become hyperemic and oedematous, diminishing the mucociliary escalator function in the bronchioles, resulting in luminal obstruction from the buildup of mucus and debris, further increasing irritation. As chronic bronchitis progresses, the damage in the lungs will continue to accumulate, decreasing lung function over time. Alpha-1 antitrypsin is a protein produced in the liver sent out in circulation. It is responsible for protecting the lungs and the liver from damage by inhibiting the release of neutrophil elastase, an inflammatory protease released by the lungs. A deficiency in this protein can cause chronic lung and liver diseases, such as chronic bronchitis. Alpha-1 antitrypsin deficiency is an autosomal recessive inherited condition. To summarize this presentation, here is a diagram depicting the conditions needed for chronic bronchitis to occur. Here are my references, and thank you for listening.